So today I'm going to be talking about the science behind HIV treatment, viral suppression, and prevention of HIV transmission. I'll start by talking about some models that come from both theoretical, mathematical modeling, as well as evidence from big epidemiological data from jurisdictions. So the first model I'm going to present was first published in 2009, and this model was a mathematical model that was designed to investigate the impact of universal voluntary HIV testing and immediate treatment with antiretroviral therapy. In this model, it suggested that universal HIV testing and immediate starts of antiretroviral therapy could reduce transmission to eliminate HIV by 2020. And a couple of other important findings of the model were that mortality could decrease rapidly, the epidemic could start to become more concentrated within certain populations, transmission, because of viral suppression, could be reduced to low levels, and ultimately the epidemic could go into a steady decrease toward elimination. This is one of the most important slides in output from the model. On the y-axis is incidence per year, and on the x-axis is time. So what you'll see is that if there is no intervention, if no one with HIV were treated for HIV, eventually the epidemic hits a plateau and stays there. That's the red line. If, however, people are started on antiretroviral therapies based on their CD4 counts, what happens is the incidence, new HIV infections, goes down, but they don't go down very rapidly or very far. So you hit another plateau that's pretty far away from zero. On the other hand, if everybody is tested for HIV and they immediately start antiretroviral therapy, what happens is the green line. And what you see in the green line is a significant decrease over time that goes down to approximating zero. So in the model, HIV treatment could mathematically be the way to end the epidemic of new infections. When you leave the mathematical theoretical model and look at some models from other jurisdictions, very similar things are seen in real life. This is a model of what happened in Vancouver, in British Columbia. So the model shows what happens as antiretroviral coverage starts to increase and community viral load decreases. Ultimately, what you see is a decrease in the number of new HIV diagnoses, and that the correlation between the number of people on antiretroviral therapy and the number of new HIV diagnoses per year is significant. It's also important to note that this was even visible in injection drug users. So the data from Vancouver was used to really support the idea that HIV treatment was powerful HIV prevention. And when you look at it on a graph, you'll see a blue line that increases. That's antiretroviral coverage in the jurisdiction. What you'll see is that as that antiretroviral coverage increases, you also see decreasing in the new HIV diagnoses. That's the red line. So as antiretroviral therapy was scaled up in Vancouver, you saw a significant decrease in new HIV diagnoses. And the green line are among injection drug users. So even in a high transmission risk exposure. Similar data come from San Francisco. They show community viral load as blue bars. So you see that there over time are decreases in the amount of viremic folks in the community. And as you see less viremia in the community, you see both incidence, which is the red line with the triangles, and prevalent HIV diagnosis or new HIV diagnoses going down over time. So as the viral load in the community goes down, new HIV infections go down. Really, again, looking back at the mathematical model presented earlier, really supporting from the jurisdictional perspective that really people who are virally suppressed do not transmit HIV. And this is the story of the epidemic in New York City. And what you see is that there have been significant declines in new AIDS diagnosis and HIV-related deaths in the mid-90s with the introduction of antiretroviral therapy. In 2001, we learned more than just new AIDS diagnoses. We also learned about any new HIV diagnoses, and you see that this line, the black line, is going down. And when you look at condom use over that time, it's been relatively stable. The only significant change has been that more and more people have been virally suppressed. So this, I believe, is also evidence to demonstrate that new HIV diagnoses decrease as more and more of the community of people living with HIV are virally suppressed. And in New York, what this means is really that vision presented in the mathematical model of nearly almost 100% of people aware of their status, of 94% of people aware of their HIV status, high levels of retention and care, and improving viral suppression every year is the driver that has been decreasing new diagnoses in the New York City jurisdiction for many years. Pre-exposure prophylaxis doesn't really enter the scene until late 2015 or 2016. So most of the gains that we see really support the models from Vancouver, San Francisco, and the previous mathematical model that viral suppression is an extraordinarily strong driver of HIV prevention. Now, leaving the jurisdictional mathematical models, we can look at some clinical studies that look at this on the patient level. The first to talk about is HVTN-052, a phase 3 two-arm randomized study that looked at whether antiretroviral therapy can prevent transmission in HIV serodiscordant couples. They enrolled about 1,800 serodiscordant couples at 13 sites. Most of them were heterosexual, and they were randomized to either start HIV medicines immediately or to wait until their T-cell count drifted down to 250 or they had another marker of HIV-related disease. What the HVTN-052 study showed is 8 linked partner infections that were diagnosed after the index partner started antiretroviral therapy. It's notable that 4 of those infections occurred before or soon after the index partner started antiretroviral therapy, meaning they had not yet achieved viral suppression, and 4 occurred after the index partner failed antiretroviral therapy because of resistance or some other cause. Now, when you look more carefully at the study, what you see is that there is a 93% reduction in HIV acquisition when you look across the study. That means a 93% reduction of an already rare event. And the linked transmissions that we saw were in people who were not virally suppressed. When you limit the analysis to individuals who were virally suppressed, there were zero new transmissions that occurred when the HIV positive partner had stable viral suppression. So individuals who were virally suppressed in this study did not transmit HIV. Another study, the partner study, actually looked at serodifferent couples who had a different story. The HIV positive partner was already virally suppressed. The HIV negative partner was not on pre-exposure prophylaxis, and they confirmed that they weren't using condoms for sex. So the only criterion for entering the study really was that the HIV positive partner was virally suppressed and the HIV negative partner was not on any sort of prevention like PrEP. And then they looked at molecular analysis to see if any new diagnoses could be attributed to their HIV positive partner who was on HIV medicines with good control. And what they found in the study that included many more men who have sex with men couples was that there were no documented cases of within couple HIV transmission during condomless sex when the HIV positive partner is virally suppressed. You'll see a bunch of boxes that are lined up across 0, regardless of what the sexual activity was. So the partner study says that there were 0 numerical transmissions between partners. Now, there were transmissions in the study, but not between primary partners. Some HIV negative people acquired HIV, but that HIV did not have a molecular match to their partner's virus. So it's from outside the relationship, really making the point that PrEP is still a very important tool in people, even if they're in serodiscordant relationships, given that they may also have other sexual partners. Now, another study I really think is important to look at is the Partners PrEP Demonstration Project. In this study, serodifferent couples were recruited. The positive partner was offered treatment, and the negative partner was offered PrEP. They were able to choose whatever they wanted to do. The idea was that when they started these interventions, the HIV negative partner would stay on PrEP for 6 months while the antiretroviral therapy got their positive partner virally suppressed and maintained viral suppression. Then what they looked at was the possibility of transmission. Now, they had a very high level of retention. A lot of people used PrEP. Many people initiated antiretroviral therapy, and levels of adherence were great. In the study, 20% of the time for follow-up was looking at PrEP alone. 33% was looking at that overlap time between PrEP and antiretroviral therapy. Almost 40% was looking at antiretrovirals alone, and 7% of the time was looking at people who elected to do neither PrEP or antiretroviral therapy. So by combining these interventions, they have found a high level of protection against HIV. Incidence of HIV was reduced by 97% from expected in men, 93% from women. They also saw that even youth were protected, and also individuals with higher viral loads. So they expected to see 83 new infections in the study, but what they actually saw was only 4, resulting in a 95% overall reduction. Now, who were those 4 people? Those 4 people were individuals who were in serodifferent relationships who either had partners who did not elect to go on therapy, or they themselves did not go on PrEP. So anybody who touched an antiretroviral in the study did not transmit or get HIV. So viral suppression, when you use PrEP in some combination, those two together, in effect, remove the risk of HIV transmission. Now, the opposite ATTRACT study is another one that focused on homosexual males, or MSM, in serodisordant couples in Australia, Bangkok, and Rio. About 350 couples were enrolled. They were followed for about 590 years. The couples reported about 17,000 acts of anal intercourse without a condom. And what they found in the study was 0 link transmissions, no matter what, as long as the individual, the person living with HIV, was virally suppressed. So the message on this one is as well that HIV positive men who have sex with men who are on treatment that makes their virus undetectable do not transmit HIV to their partners. So there are a lot of folks who may deny this data. They say, yeah, this is true, but there's a lot of reasons why people may still transmit HIV. They may say there's detectable virus in people's genital fluids, so they could transmit the virus. They also say that people have blips sometimes. They have virus that is occasionally spikes in their blood, so they could potentially transmit HIV during those transient spikes. And also, that if somebody living with HIV has an STI, they could transmit HIV because their viral load becomes detectable. Ultimately, it may feel comfortable to agree with the naysayers, but the data demonstrate over and over again that even though there's some theoretical situations where someone may transmit HIV if they're virally suppressed, they just don't do it. So very similar to the possible risk of me leaving my Department of Health office, walking on the street and getting hit by a bus, that's very similar to the risk of someone who is consistently virally suppressed transmitting HIV. So though the data are reassuring, there are a lot of folks who are still dogmatic about this, but our job as scientists and clinicians and other folks who support the community is to remember that our job is to be science over dogma, and really the science says that undetectable is equal to untransmittable. So, to review, mathematical and jurisdictional models demonstrate the potential and observed benefit of viral suppression. Clinical studies support that individuals who achieve and maintain viral suppression do not transmit HIV, and it looks like combination biomedical prevention, that's PrEP for people who need it and treatment for people who need it, and some combination of the two is a very powerful way to end an epidemic, given the fact that it may virtually eliminate HIV transmission. So it's really important to remember data over dogma, that ultimately the data shows viral suppression means that transmission is in effect eliminated. Effectively, you are not infectious. Thank you.
Thank you again, Dr. B. Go ahead and
was drafted by the lead researchers from the 3 main studies, and also from Swiss Statement, the author of Swiss Statement. But what we needed at that time was a public official, someone with a major voice voice in the US and also on a global scale that would sign on and that was unaffiliated with the studies. And so I went to actually quite a few different places and had the door closed in my face. And a lot of people said, we agree with the science, but we don't want to say that because for various reasons, people with HIV will stop using condoms. They won't understand what it means that you have to be adherent in order to stay undetectable and untransmittable. So I'm very proud to say that I'm a New Yorker because Demetre and New York City Department of Health, within, I guess it was about 2 weeks after we sat down, and Demetre didn't hesitate. He said, absolutely, absolutely, the data doesn't lie. And within 2 or 3 weeks, he had City Hall signed on, and it was the first endorsement, major endorsement of this message, which is negligible risk at the time, which is still consistent with U equals U. And then right after that, NASDAQ came on without hesitation. We were thrilled about that as the first NGO, and Housing Works as the first AIDS service organization. But it was still a battle in many cases at that point. It was, even though we had these major acres behind it, we were still did a lot of fighting, and now we're doing a lot more educating. So at that time, we were really lucky. Also, Terence Higgins Trust in England and AID in France were had national campaigns that were already launched, but there was really nothing else in the world at that time. So we say the campaign was really born in New York City, and then it grew up in Canada. When Katie signed on, it went global. Right after that, we had sort of IAS and ICASO and AIDS Map all came on, and it really started to grow very, very quickly. There's some organizations around the world. Really, these organizations you see here are the innovators. They came on early, even before the CDC, even before UNAIDS endorsed the message. So these are all the organizations that I just feel and actually there's many more. This is only a fraction of them. One really exciting thing is we have cities and states coming on. So as I mentioned, we had New York City signed on first very early on. And Washington, D.C. became the second city in the country. They had a campaign that I'll show you in a little bit. Chicago also signed on. City of Chicago as a third. New York State Department of Health, first state in the country, signed on recently, as well as Michigan and Minnesota. And then citywide programs like End the Epidemic 2020 in New York, Getting to Zero San Francisco, Paris, and the City of London. Paris signed on this summer. City of London is saying U equals U. So now we have 440 organizations, 64 countries, 15 languages. It's absolutely fascinating. And I'm just going to show you the love here, show you some of the ways that the organizations are speaking about are changing the definition of what it means to live with HIV. So this was New York City back in December, billboards of Times Square, this gorgeous campaign. This was Washington, D.C.'s U equals U campaign this summer. This is the city of Paris. This is City of London, Do It London. They use undetectables on infectious and link to our site. These are the world leaders. Terence Higgins Trust had the first campaign in the world a little over a year ago. And the French also came on the aid very early on. They launched a campaign, a 70-city campaign, the black and white one. And then the one on the left is their summer campaign, their Pride campaign. Aid is the largest AIDS charity in Europe. This is New York City. Housing Works, awesome campaign. Planned Parenthood came on. The British HIV Association, ACT UP Dublin has been very engaged. Mount Sinai Institute of Advanced Medicine. I think this is interesting. They're using this in their testing campaigns to start to destigmatize HIV. This is in Spanish, I equals I, N equals N. In Dutch, U equals U. In Turkish, H equals H. In Macedonian. This is the only gay health clinic in Guatemala. This is the French campaign that was the first, the Italian campaign just launched yesterday here at the European AIDS Conference. Very beautiful U equals U campaign. On the left is the Russian campaign that just launched. On the right is the Czech campaign, another Netherlands. And then a major pharmaceutical company is endorsing it as well. So this, I think, is cool. And we're seeing individuals all over the world actually creating their own kinds of messages. And I thought this was cool because Victor from the US created a similar campaign to William in Uganda, in very similar messaging. It's just kind of cool. And then we'll see on the left is Belfast, I t-shirts. We're in Madrid. On the right is our friends in Kampala. On the bottom is Lyon. Bottom left is England, and in the middle is England. On the top left is New York City. Top right is Manchester, England. And bottom right is Montreal. Bottom left is Chicago. So you can see people are rising up all over the world. These are just a smidge of examples. But one thing we really need to be mindful of going forward is the third U, unequal. There are many, many economic, social, structural, legal barriers that make it impossible or difficult for people to reach and maintain an undetectable viral load. So we really need to use the U equals U public health argument to demand access to treatment care, viral load testing to leave no one behind. We just formed a partnership with International Treatment Preparedness Coalition Global to work on this very thing, and we have a section on our website called The Third U with lots of resources on this. We also, in addressing communities and educating about U equals U, need to also be mindful of communities and understand who will be most effective to engage people that have a long-standing history of being neglected by the healthcare system and have competing priorities where food insecurity, housing, poverty are the top priority. So everyone needs to know this information. It doesn't mean the information should be gatekeeped and blocked from them. It means it just needs to be shared in the right way by the right messengers in a sensitive way that's, the way that's sensitive to the realities of their experiences. And criminalization is very important to look at how this unintendedly criminalize folks that have a detectable viral load by writing into law that if you're undetectable, the laws aren't subject to you, but because you didn't put anyone at risk, but detectable folks do would be subject to the law. So that's another thing to keep in mindful about, as well as the stigmatizing language around detectability. Now, just before, if there's anything I'd like you to take away, is when you talk about this, please be absolutely clear, because we're talking about the risk from a human being. When you talk about the risk from a human being, you need to be impeccable. Don't leave wiggle room for risk, because many of us living with HIV and folks who carry fear and trauma from the plague days and those who wish to harm us will find a window to confirm that we're dangerous. They will find ways to confirm their preconceived notions of people living with HIV. And this is not about, we're not talking about the efficacy of PrEP or how likely you are to get into a car accident or fall into a sinkhole. This is the risk from a human being. So here's some examples of what we've seen work and not work with our partners. This is on our website, so it's probably easier to just go through it then for the interest of time to look at it at some point. But just be clear, there's language that will convey there's still a risk, and language that will convey there's no risk and will reduce stigma. And when you're thinking about messaging, the main thing to think about is it's actually not that hard. It's not that complicated. It's about adherence. The medicine works if you take it. So to stay undetectable, take your medication every day. This is about sex. This is not about needle sharing or breastfeeding. This is just one option in the prevention toolbox, which also includes condoms, which will prevent STIs and PrEP in some parts of the world. And the focus is keeping us healthy, we're not prevention tools, so keep an eye on your messaging around that. Also be aware of judgmental messaging about people's level of viral load or their choice whether or not to start treatment, and sexuality and sexual practice. So just before we leave, this may be going through your mind, because it still goes through my mind, is that you may be still feeling some internal resistance, and that's the cognitive dissonance, because for so many years we're trying to unlearn 35 years of fear of people living with HIV and fear of HIV that we've been taught. And so try not to let your subjective feelings and experiences guide you here. And we usually say, trust your gut, but maybe not in this case. Maybe trust the experts. And I mean, I even feel insecure at times about this, and I do this every day from morning until I sleep. And so one thing I would say is borrow confidence from the experts. Just borrow confidence. Think of what the experts are saying, because I'm not an expert, and most people on this call are probably not experts in transmission risk. So we'd love you to join us. I mean, people living with HIV, as you saw around the world, and with our allies, we're changing what it means to live with HIV in so many exciting environments. Our website has lots of resources for you to join and learn about the science and all aspects that we talked about earlier. You can sign up as a community partner. There's the 5 agreements online for signing up. But most importantly, say it. Please tell somebody, and say it in your own way, but say it accurately, and make sure you tell people, because people still don't know, and everyone deserves to know. So you can really be a part of history making if you join us and you share the news in a way that works for you.